Afternoon. I don't have slides either, so I won't go over either. And so I have a few initial comments. First of all, I am Dave Thomas from the National Institute on Drug Abuse. I have 2 IDs, so nobody can doubt me on that. I don't know how that worked out. One of the initiatives, why I'm here is I lead the NIH Pain Consortium's Centers of Excellence in Pain Education. We're trying to get into pre-licensure training. We're making modules and trying to promote pre-licensure training on pain. And I'm also the lead on the National Pain Strategies Provider Education Committee, where again we're trying to change it. So getting pain education is the norm, not the exception. The National Pain Strategy, it was mentioned a few times today, and it keeps coming up. It's unfunded at this point, even though we have a lot of HEAL money. It's not directed towards the National Pain Strategy, but it is a comprehensive population-based strategy to do a number of things to help people in pain, including better provider education. So we're trying to move that along as best we can. Let me just say a couple. I didn't know if I was just going to comment on your talk, and I do have a few comments, but I wrote some stuff down anyway, just in case I didn't have anything to say. But I would like to note that pain education is not about facts. I mean, you don't have to go to a clinician and figure out. He doesn't have to know how C fibers organize or how it works exactly. They have to learn how to treat people better, and that's part of the problem. And that's why with our educational modules, we're giving case studies of here's a person and here's how you might approach them. And if you've seen one pain patient, you've seen one. There's so many different varieties, and we're trying to make a variety of different modules. And part of what we're trying to do with our educational modules is to address misconceptions. The idea that pain's in your head. Or one of my favorites is if you treat the disease, the pain goes away. That's not true. Okay, sometimes it is, sometimes it's not. And then the stigma around pain. I mean, you have somebody come to you, they're in pain, maybe they're drug seekers, maybe they're just complainers. And stigma is our enemy in this, and education can help reduce the stigma. So, and if there's one thing that I would like to see with pain education to happen the most is just caring about people in pain. Empathy for people in pain goes down in medical school. They learn you're not supposed to take care of people in pain. They're a problem. And that's not the way it should be. We should keep the empathy, keep the caring. And that caring can pay dividends in that if you care about people in pain and you see it as a priority, then down the road you're going to keep getting training, and it's going to be a priority for you and your treatment to take care of people in pain. We've talked about the HEAL initiative, a lot of great stuff happening, better metrics of pain, pragmatic trials, better study of the transition from acute to chronic pain. All sorts of things are happening that's going to make our understanding of pain better. And integrative health is a big part of it, and it should be a big part of that. That's for sure. But the education, and this is the argument I made for more education at the NIH. We'll spend all this money and we're going to do good stuff, but if we still have clinicians that don't know what they're doing, we might give them better tools, but they don't know how to use them. So that, I think, is something we have to, that underscores the importance of education again. In terms of Scott's talk, he made a couple comments that I felt like I had something I could mention about it. Why the education gap when it comes to pain? And I think it's kind of simple. We don't care about people in pain. I mean, historically, our society doesn't care about people in pain. And given the health problem it is, we should be putting so much resources, which we are now, but we should have been putting resources all along to help so many people in pain. And the good news is, the silver lining is that we are now starting to do that. So the challenge is to make sure people in pain don't get crushed, and education can help with that as we fight the opioid crisis. But I think this is all a good thing. We're moving in a good direction. And then the other thing that Scott mentioned was that pain doctors, or to become a clinician, you get a lot of teaching about how to identify pain. And this is a little controversial, but I think it's a good thing. But a big part of our HEAL initiative is trying to get better metrics of pain. And part of that is for drug development, treatment development, but also for diagnosis. Not that we shouldn't listen to people in pain, but the way we measure pain is based on self-report is pretty much how we did it before the invention of the wheel. So as we as we want to move forward, I think better metrics of pain can only help the situation. So, and I'm actually landing right on time, so thanks.